Okay, my review is really based on two of our own people, Jerry Lycan and Bill Watson, and it's really a review paper on post-mortem toxicology. Big issues that they really raised were really a lot of questions and not a lot of really very specific guidelines, so just I'll be giving some examples that they gave themselves. I'm going to skip these 5 key concepts because you already have those in front of you. They basically start out with saying with the current state of necrokinetics, if you will, or the post-mortem toxicology, is that we really are measuring post-mortem levels of whatever your favorite substance may be, and we try to compare these levels to the typical therapeutic toxic concentration ranges, which has been considered the state of the art, but it may not be always hold true. We also go with the assumption that the concentrations don't change after death. And we know from a few examples, and he provides several on this in the paper. So the concept is incorrect. Post-mortem changes, this is actually a copy of, I believe it's table 1 in the paper. Post-mortem changes that must be considered for all but a few drugs. So this is the example of a list of drugs that really do not have post-mortem changes. And I starred, and in the paper, the one that starred also is the alcohols, because he says that the post-mortem changes over time, the body with decomposition will increase the alcohol level. So that's the only exception to that. Another concept that covers the paper is redistribution can occur rapidly with some of the medications involved. 2 examples specifically given here are thiopental and pentobarbital that have significant increases, but only in the first 4 hours post-mortem. The other example was morphine, which also has significant post-mortem increases, but within the first few minutes. Other examples of ongoing absorption or redistribution. Ethanol in the stomach can contaminate the pericardial blood. He does caution, however, at least based on the reference, that you need about 400 mLs of a 10% or 10% ethanol for this to occur. So it does take a fairly significant amount. And if this were to occur, then a femoral vein sample under these conditions, the femoral vein sample done with alcohol in the blood, this does not occur. So that would be the best specimen to obtain, would be a femoral vein specimen. There's also this concept of the cardiac to peripheral blood ratio. And if a drug has a high cardiac to a peripheral ratio in the blood, they have a greater potential for redistribution. So therefore, cardiac pericardial samples tend to be high and not really correlate with the typical clinical samples that we would be obtaining under normal conditions. So you really need peripheral samples. I did not copy table 2 here. Again, the paper has lots of tables, but it does provide a table of where to look at what those ratios are for specific drugs, for examples. Another key concept here. Basic drugs tend to bind to the myocardium and therefore then leak out and contaminate, if you will, cardiac blood. With time. And examples that he provides here are the tricyclic antidepressants, cardiac glycosides, local anesthetics, and the opioids. And therefore, this may result in increased heart blood concentrations where in real time of death, they were not as high at that point in time. Another big issue, serum versus whole blood. Just clinically, in general, we tend to use serum samples. Whereas in the medical examiner's office, post-mortem, we tend to get whole blood levels, and this can affect certain products. For example, the difference for ethanol values, plasma versus blood, is about a 12 to 18% difference. And you may need to take this into account as you're interpreting alcohol levels as a cause of lethality. For cannabinoid samples, there's a factor of 1.6. Not that I know of too many people have died just from cannabinoids as a cause of death. Volume of distribution. Drugs with, again, high volumes of distribution are candidates for redistribution from tissues back into the vascular space, and he provides several examples, again, via tables. And instead of copying the tables all over here, because again, they're very long with long lists of different chemicals and medications here. I just summarized them here just so you know at least what to look for and what potentially could get tested on these things. Table 1, again, I did copy that at the very beginning, it's just the drugs in which the redistribution does not occur. Table 2 is a partial list in which post-mortem transformation redistribution does occur. Table 3 is a recommended tissue sites to determine acute fatal poisoning. Because based on the matrix of what you're measuring, it may give you the most favorable, comparable to a clinical sample that would help predict cause of death potentially. Table 4 is the drugs with concentrated bile. Table 5 is again post-mortem blood antidepressant, antipsychotic levels that actually have proven causes of death at those levels. Table 6 discusses or shows examples where the urinary LDH or lactic acid or protein may result in a false positive immunoassay. Table 7 describes a different set of sort of just a typical toxidrome. He describes them as post-mortem toxidromes. And Table 8 are drug issues with embalmings. Again, the different embalming fixatives, if you will, can affect several samples for many different drugs. So again, it's a long table, did not want to reproduce everything here. He summarizes everything at this point with basically questions to ask as you're trying to interpret specimens or samples or cause of death for post-mortem toxicology. Big questions are sort of summarized here. Where were the samples collected from? Is there post-mortem redistribution going on? Is there any evidence for concentration toxicity relationship based on where those samples are taken from? Clinical information, do you have clinical information to correlate with these concentrations? Was the concentration clinically sufficient to cause or be involved with the cause of death? Post-mortem toxidrome, does it follow one of the classical ones of these? Was the body embalmed? Does the analyte require special storage conditions? Because otherwise you may have changes occurring over time because of that, the special storage requirements not being met, not put under ice or whatever. And again, do the pills, because a lot of times we get reports from medical examiners saying, we found evidence of pills of such and such type in the gastric contents, but do they actually contain active drugs? Because a lot of times you end up left with a wax matrix or whatever, but there's no actual active content at that point. So you have to watch out for that. And those was basically the questions that he really says that you need to keep in mind as you address all these cases. And just he provides some examples to some of these, and that's sort of the conclusion, if you will, to the paper was this list of key concepts and questions. Any questions?